It is still Thursday something, 6th of April. My parents have left to fly back to the UK. My son Edward is playing in a park, and my wife and my daughter Jessica are shopping. So a chance for another video. I'm going to try and be a bit closer to the computer because I think the volume was low in the last video. I should try and look at the camera even though it's placed in a really inconvenient position. So, this video is about why I am gambling on immunotherapy, really. So first of all, it's not much of a gamble because there are two alternatives. One is the palliative care pathway that I'm in with the regular Japanese hospital. Palliative care means basically just trying to help you to live a bit longer and hopefully not too much pain and suffering until the last little bit of your life. So that's a treatment pathway I'm in, which basically means chemotherapy until it stops working and then try another chemotherapy or try to add something different to the chemotherapy mix. With bowel cancer, there are just like, there's only one kind of basic chemotherapy that can be used, something called 5-FU, and then you can add oxaliplatin, which is a platinum-based toxin, or you can add some irinotecan, which I think is another metal-based toxin. And then you also have a vitamin that helps the 5-FU work better. And then these things could make targeted therapies, which are designed to attack the cancer cells directly and somehow damage them. So the one I'm taking is Avastin at the moment, which stops new blood supply in your body forming. So when a cancer kind of gets to a certain size, it basically outgrows its blood supply, so it needs more blood than it's getting from whatever blood supply it's got. And there more blood supplies will kind of sprout. I think they sprout, yeah, you'd imagine they sprout from the cancer to outside, but I think they actually go the other way around, really odd. But Avastin blocks the formation of new blood supplies. The targeted therapy I had before, which was called panitumumab, that works by like smothering the cancer cell. So it looks for a certain protein called something like epidermal growth factor, something like that. Obviously, the name epidermal suggests that it's found a lot in the skin, but it is also found in cancer cells for some reason, and maybe lots of other cells in the body. But it kind of panitumumab smothers them, kills them in that way. So different molecular therapies. Although those two families, the one that includes Avastin and some other stuff, and then panitumumab and Erbitux, that kind of, it's like the two families basically seem to be the only ones for bowel cancer. So that's the treatment path I'm in. Which to a large, very, very large degree is expected to result in my death kind of soonish, really. Because the cancer can't be cured by chemotherapy, basically. However, there are absolutely some people who are diagnosed with terminal cancer today who will be in the palliative treatment path to extend their life and try and make their death less painful, who will actually live long enough for new treatments to come up. From what I've been told by the doctors, it's unlikely that would happen to me. because the treatments that would potentially work for me are kind of a couple of years away. In fact, it's a family of immunotherapies called checkpoint inhibitors, which send messages to the cancer cells to say, now's the time to die. Cancer cells, for some reason that I don't really understand, are able to inhibit the message that tells them to die. I think checkpoint inhibitors inhibit the inhibition of something called like PD1, PD2, so the program death messages. So those checkpoint inhibitors are a couple of years away. In the past, for people with bowel cancer that spread to the peritoneum and other organs, chemotherapy has not kept them alive for 2.5 years. It just hasn't happened. However, there's always a chance, just because the chemotherapy is kind of improving in terms of people are now able to have chemotherapy for longer because doctors, particularly doctors in Japan, are getting better at dealing with the side effects. And often in the past, it's like people got to a point where the side effects are so bad you have to stop the chemotherapy. Now that still happens, but that point is kind of later. Occasionally, new chemotherapies come along, which means that when they get to the point where the cancer is resistant to the current chemotherapy, which is expected to happen with me quite soon, you can then switch to another chemotherapy. And the other big thing is these molecular targeted therapies that are pretty recent. I think in many countries only in the last kind of 5 years or whatever. In England, because the people who control health policy are utter idiots and spineless, molecular targeted therapies are kind of not widely available. And particularly the one I'm on, Avastin, it was available for, I think, a couple of years, not through the main healthcare system, but from this top-up fund, the Cancer Drug Fund. It's now been removed completely, so you basically can't get Avastin unless you can pay for it privately. So I decided to gamble on immunotherapy. First of all, it's not much of a gamble because of the 3 treatment paths, kind of the standard palliative path I was in, or am in rather, which results in death quite soon. The so-called mother of all surgeries, cytoreductive surgery and HIPEC. That was another option which I'm currently not pursuing because I think because it seems to be impossible to get specific information about the outcomes of that surgery, and it's possible that there's some kind of bad mathematics happening, completely understandably, which is just that the people who have this surgery, of which overall 40% live for 5 years, which is incredible for people with terminal bowel cancer. Well, no, I should actually correct what I just said. That 5-year, 40% 5-year life expectancy, that includes people with lots of different types of cancer that spread to the peritoneum, so like ovarian cancer, cancer of the appendix, asbestosis, kind of lung cancer caused by asbestos, and kind of a couple of different types of peritoneal cancer. So that data is kind of a big group of people, and people like me would be in the subset of the group that get poorer outcomes. But another really important point is that a big reason for that good result is patient selection. So in the past, they were just trying it with lots of people who their cancer had spread to the peritoneum. Now they're far more selective because they have a better idea about who gets a good outcome and also who can even survive the surgery. Makes perfect sense and is obviously correct. But think about what it does to the data. Those kind of people going for that surgery, basically fit, healthy people who are dying of cancer. You could, like me, I don't have poor health other than I'm about to die of bowel cancer. And I can't walk at the moment because the chemotherapy has weakened my immune system and I've got my left foot is infected, so I'm on antibiotics to try and fix that. But other than that, I can eat by myself, walk around, that kind of thing. I can't walk at the moment, but in principle I can walk. And breathe okay, that kind of thing. So those people that are candidates for that surgery, that 10-hour procedure with massive aftercare and stuff, those people potentially might do quite well with chemotherapy without that huge surgery. So it's like in a way, it's kind of the healthiest, fittest people in the population who have terminal cancer that spread to the peritoneum. They're the people that can try having that surgery and potentially get good results with that surgery, but we don't know if they didn't have that surgery. There might be people that could have loads and loads of chemotherapy for a long time and may do really well on that, may live several years on that with a reasonable quality of life. So there's not much of a gamble, really, to choose the third path, which I'm choosing at the moment, which is palliative care. So kind of trying to make me live a bit longer and keep my quality of life good using chemotherapy and molecular therapy. But plus, I'm doing 2 types of immunotherapy and hypothermia therapy. So hypothermia therapy is heating up in my case, heating up the abdomen where that cancer is. And there are various reasons and various mechanisms by which the cancer is damaged, possibly even destroyed by the heat. Odd things happen. The cancer cells make these things called heat shock proteins, and there's a group of heat shock proteins called heat shock protein 70, which guide chemotherapy agents towards the tumour. Sounds ridiculous, but it seems to be true. There are other ways that the heat kind of damages the cells so that at the temperatures I'm having probably wouldn't expect it to kill the cells, but it makes the cells weak to water. So water molecules from the blood go into the cancer cells and the cancer cells burst, which sounds really good. So there's 2 things. There's actually 3 other ways that that targeted heat seems to affect it. And then there's the immunotherapy as well, of which I'm having 2 types, a vaccine type and an autologous type as well. That's why I'm choosing that path, really. More videos coming soon. If you can possibly donate to this terrifically expensive immunotherapy, methadons.org is the site. Thanks for listening.